Inequity is everywhere when it comes to health and healthcare in this country. But few cases are as stark as that of sickle cell disease, a painful and debilitating hereditary blood disorder that primarily affects Black people. Sickle cell disease, which contorts red blood cells, leading to blockages, organ damage, and a shortage of healthy blood cells, affects an estimated 73 out of every 1,000 Black infants. That's more than 10 times higher than any other racial group. And while we've known about this painful and debilitating condition for more than a century, treatment options are still extremely limited, and research often goes underfunded. Well, right now, I'm joined by Dr. Charles Azar. He is the medical director of the Comprehensive Sickle Cell Disease Treatment Center at Mass General Hospital, and Carissa Juarez, a patient ambassador for the Massachusetts Sickle Cell Association, whose 11-year-old daughter has sickle cell disease. Welcome.
Hello.
Thank you for having me.
Well, Carissa, you know, when we spoke to you about booking you for this show, you said your daughter's in sickle cell crisis as we speak. What is that like for folks who don't quite understand what it is for families to go through this?
It's really tough. I'm a single mom with 5 children, and she's the only one that has sickle cell disease. So it's hard to manage with all the children. I have to bring her in. She actually, this time, she didn't get admitted through the emergency room, which normally she would, but she was admitted directly through her clinic because she went there to see if she can get some pain relief, but it didn't work. And so they had to admit her for some more IV pain medication. She's been there since last Wednesday. She's still there. Still in a lot of pain. I just got off the phone with her. Unfortunately, I can't be there because I'm with my other children right now. So it's tough because it's trying to go back and forth to the hospital, also managing things at home. And I just want to make sure she's getting the right care also while she's in the hospital. And it's kind of hard when I can't be there physically. But I'm working as much as I can with the hospital to make sure everything is going out fine. It's really tough. I feel bad that I can't be next to her right now. And she is in a lot of pain.
I could only imagine, and we have been talking about how treatment plans and options are very limited. Dr. Azar, I read that, you know, just about a month ago that some gene therapies came online as a possibility, but I imagine those are very expensive. We know about bone marrow treatments or transplants. That's an option, but it has to be tough, I imagine, the access piece for something as complicated as that type of procedures.
You're absolutely right. I mean, while we're very excited about the prospect of gene therapy, and we're really excited that those are coming down the pipeline in hopefully very short order, access is going to be a tremendous issue going forward. And I think ultimately we have to remember that even if these were to become standard of care here in the United States, the vast majority of people living with sickle cell disease live outside of the United States. And it's hard enough already to be able to get those patients access to even basic medications to treat the disease. It's hard enough to do that here in the US. It's also going to be a bit of a mystery to determine who is going to be selected for gene therapy up front, who would benefit and who wouldn't benefit. There's a lot of unanswered questions, including ultimately what the cost is going to be to patients who receive it. We anticipate that it's going to be an expensive intervention.
I also know that access to just the treatments we have, pain medication, which seems to be the most common and the one that is the most accessible, can often be a challenge. I've had conversations with you, Carissa, about how difficult it can be to get access to that pain medicine when your child is in pain, is hurting.
Yes, it is. Several times we've been to like the emergency room where they'll be like, okay, let's give her some ibuprofen and some oxycodone. And I'll say, well, if that was the case, I would have stayed home, you know, like she needs more than that. We're not coming here for that. That we can do at home. We're here because we need IV pain medicine. And it's tough. Unfortunately, even as a child, it's more harder for adults and teenagers. But as a child, it's like, I don't know I don't know what's going through some of their minds, but to go there and present my daughter and she's having a crisis and having to wait sometimes more than 60 minutes to just be seen. Okay, and there is rules and policies in place that you're supposed to already been in a room, already accessed if you have a port or an IV that needs to be placed, and already have pain medicine going through you within 60 minutes. And unfortunately, this is not happening in the emergency rooms. There's staff that's not even trained to access ports. My daughter has a port because she gets blood exchange transfusions. So she has a double port, and they don't have trained nurses in the emergency room for this. So this is a problem. And then when we're there, it's like, to get the pain medicine, yes, there is a problem a lot to get pain medicine. There's like, I don't know if it's just ignorance. I'm not, I really don't know, but it's like, my daughter's not here because she wants to get high on something. Okay. She's here because she needs this medication. We already tried everything we could at home. So it's tough. And then even when she's inpatient, I feel like sometimes she's rushed to get out. I'm having that somewhat of an issue right now where she was in on Wednesday and already on Friday, they're like, okay, we think we're going to start her back on oral medications. And I had to explain to them, yes, we did come in on Wednesday with some back pain, but that same day that we came in with back pain, even though that back pain has been existent for a few days, she started sickling in her foot. That's day one of a sickle crisis in the foot. That means by day 3, she's at her peak. There's the peaks that we go. And so that means that now she's in more pain. So I don't want to rush her. I try to explain this. Well, maybe every patient is different, but with her, it's like we'll go a few days where it's a pain that she can handle, and then the pain gets higher and higher, and then it starts to come down and down. So given that her back was already hurting, but then her foot just started hurting the day of admission, no, that foot's gonna get worse.
Yeah.
So I try to explain, and that's what happened. But it's challenging. It's really challenging.
I can imagine. Dr. Azar, how difficult, or perhaps not difficult, is it to have these conversations with other healthcare professionals when you have moms like Carissa who bring in their daughter in and they're like, I'm at a 10. This is what we need at a 10, but there are hospital procedures that maybe contradict that. There are perhaps, training, experience that maybe contradict that. I mean, how do you have conversations in the healthcare space among professionals about this?
It's such a great question. I mean, you can hear the frustration in Carissa's voice, very appropriate frustration as a parent looking at their child when they're in extremis coming into the emergency department. We have to have this conversation almost every single time a patient comes into the hospital. Part of the beauty of our team is that we have 2 dedicated nurse navigators. And oftentimes what those nurse navigators have to do is go to the bedside in the emergency department or on the floor and sit there and hold the patient's hand while asking the nurses to please push an additional dose of pain medication. I can understand where some of my colleagues come from. Many of our patients are on, higher doses of opiates. They may be uncomfortable. They may not be used to those types of doses. It all comes down to education. A lot of what we do is trying to help our colleagues to understand that our patients have been on these pain medications since they were infants in many cases. And they are very used to these doses of medications. So we attempt to try to normalize that as much as we possibly can. At the same time, there's also an enormous racial bias as our patients are coming into the emergency department. And we have to help other providers oftentimes come to terms with their own racial biases as they're treating our patients.
And I know that there's also different types of sickle cell disease, and I think a lot of folks don't realize that. Will you speak a little bit about that?
Sure. So yeah, there are several subtypes of sickle cell disease. When we talk about sickle cell anemia, we talk about people who have inherited 2 copies of hemoglobin S, the aberrant form of hemoglobin that leads to the disease. But there are other subtypes where that hemoglobin S is paired with some other mutation in hemoglobin. Hemoglobin is the protein that allows our bodies to carry oxygen around in our red blood cells. So there are variations on the disease based on what the mutations are. The textbooks will tell us that some of these subtypes are supposed to be less severe than other subtypes. But I oftentimes toss that aside when I'm talking to medical students or residents, because I have found that patients who have the subtypes of the disease that the textbooks will tell you are less severe have every bit as many complications as my patients who have the subtype of the disease that's thought to be most severe.
So does that change the way treatment is applied depending on what subtype of the disease you have?
To some extent, yes. There are some subtypes of the disease that affect organs differently. So there's one particular subtype of the disease, hemoglobin SC disease, that affects the eyes and the bones more than other subtypes of the disease. Hemoglobin SS disease seems to be more prone to causing neurologic complications. So we think about them in terms of the complications associated with each of the subtypes. But at the end of the day, I try to de-emphasize that as much as possible when I'm talking to my colleagues, because I want my patients with sickle cell disease to be treated the same regardless of what subtype they have.
And Carissa, I know that you are absolutely the #1 health mom advocate, mama kit, for your daughter. How do you also try to keep her life as normal as possible at 11 years old?
It's tough. I tell you, I recently had to transfer her out of a school that she was in because they were excluding her from a lot of things, and she was put into a classroom, a very small class with students who were also disabled. But she just felt like she wasn't part of the other students, like, not having a normal life. And she just looked so depressed all the time coming home from school. And so, I try to go over the IEP with them and try to negotiate with them. Like, let's try to put her like in a different classroom and stuff. It just didn't work out. So I did transfer her to that school, and I actually put her into the Walpole School, public school systems, and they're awesome. They have done a great job. She's in a bigger classroom. She does have a one-to-one health aide, just in case, of stroke and stuff like that, because she has suffered a minor stroke before. And just for other reasons, like if she starts to sickle in her legs, then she needs wheelchair at school, because I try to keep her at school as much as I can. She'll have somebody there to support her. But they're great. She's been happy. Like, she has this huge smile on her face now, which makes me, I feel like an elephant has just came off of my chest. They're awesome. They're working, they work all together. They're already getting her prepared for middle school. They're already talking to the nurses there. It's been great. It is a challenge. It's challenging because another thing is she can't be in the snow. She can't be in the hot weather. Can't be a cold pool. And she has siblings, and they want to have all this fun too. And I feel bad because she can't do all these things. So we try to do things like shaving cream mixed with like baking soda to do snow in the house, or we'll try to find other things that we can do. Taking into consideration, I'm a mom who's not working, because I'm constantly taking care of Jaleesa. So it's hard for me to financially afford other things too. This is a really tough thing. Living with sickle cell doesn't only affect the patient, it affects everyone else surrounding her. Her family, her friends, her siblings are like always sad and depressed. This is school vacation. We're supposed to be having fun all together. And she's in the hospital. I was going to try the aquarium and everything, and it's like, we can't do this right now, and I feel bad to take everyone else, and she's not there.
I imagine also, there has been a conversation where there's a bill in Congress right now to provide more aid for services, and a conversation around having that both on the national side, but also right here in Massachusetts. Dr. Azar, in the last moments that we have here, how helpful would that be for families like Carissa's?
It's enormously helpful. So we have an omnibus bill that has been introduced to the Massachusetts state legislature that we're hoping to get through later this congressional session. And if we can get it through, not only would it allow resources to be given to sickle cell programs around the state, but it would also help to prop up community-based organizations like the Mass Sickle Cell Association that are working hard to try to normalize the lives of patients like Carissa's daughter. But at the same time, we can also help to normalize the laws surrounding opiate management and prescription drugs. So many barriers that have been put up that really require a top-down approach. This is a great way to be able to do that right here in Massachusetts.
Excellent. Well, I want to thank you both for your time, Dr. Azar, Carissa Juarez, and good luck to your little girl. Absolutely.
Thank you.